Okay, thank you, and thanks for the conference organisers for inviting us to Mark and myself to talk about our approach to drug-related death monitoring across Cheshire and Mersey. So let's see if we can get this going. Okay, so efforts to understand and prevent drug-related deaths are not new. I think the debate is more around how effective the implementation of policies and what we know about preventing drug-related deaths has actually been put into practice. If we go back some time, in the 2000 report, the Advisory Council on the Misuse of Drugs made this statement that in our judgment the prevention of drug-related deaths is not just topical but is a matter of pressing urgency. The number of such deaths should, can and must be substantially reduced, and we believe that the advice given in this report will help to achieve that goal. And I think actually it did, and had we carried on with some of the advice contained within that report, we might not be in the situation that we're in now. Following the report, there is also a government action plan on reducing drug-related deaths, and actually between about 2000 and 2004 we did see a national decline in drug-related deaths in the UK. That success unfortunately was fairly short-lived, and the kind of strategy seemed to just get forgotten about. By 2017 we were in a situation where drug-related deaths in England and Wales had hit an all-time high. The number of deaths reported in 2017 were higher than at any point since records began in 1993. And there were a number of commentators, including national drugs advisory bodies, such as the Advisory Council on the Misuse of Drugs, that were pointing out and noting that fatalities, drug-related fatalities, were highest in the areas that had experienced the deepest cuts in funding. And you can see the authority that I work in, Sefton, was certainly amongst that. 51% reduction in our drug and alcohol budget since around about 2012. So if we look at that data on a kind of a regional basis, a couple of things that I just want to point out, to make note of. Clearly there is some regional variation, with the northwest of England, where we are now obviously, being only second to the highest area for drug-related deaths in the UK, which is the northeast. There is also an association here between levels of deprivation, because if we kind of look at the map, and you know that the kind of darker shaded, it doesn't come out too clearly, but the darker shaded areas are those with higher levels of deprivation, also corresponds with higher levels of drug-related death. So makes absolutely no sense whatsoever to take money out of the drug and alcohol budgets in those same levels of high deprivation where we've already got the highest levels of drug-related deaths. But yet again, what we see is, as mentioned earlier this morning, the kind of, the poor get poorer and the ill get more ill and end up dying. Well, no surprise there. I managed not to swear. Okay, so if we take the Office for National Statistics data across the 9 areas of Cheshire and Mersey, a number of things again, apart from Liverpool is this top line. I keep pointing this, I think it's got those things on us. So Liverpool is way out there, but the rest of the other 8 local authorities for the Cheshire and Mersey region, you can see that kind of generally speaking, from about around 2010, there has been a steady increase, and that increase did start earlier, but a notable increase in the number of drug-related deaths across. So what was happening in 2010 particularly? I'm not suggesting there's a direct cause and effect here, but I think certainly an influence. We had the establishment of a coalition government, and the kind of the influence of a neoliberal mindset around cutting money out of health services, the kind of the real impact of austerity on health services. And we also had an ideological shift in the way in which drug and alcohol treatment services were both commissioned and delivered, and that was of course the whole abstinence-based recovery movement which kind of took effect there. So moving on from the kind of background and the context, what actually is a drug-related death? So if we follow the definition, widely held definition, certainly promoted by the Office of National Statistics, a death where underlying cause is poisoning, drug abuse or drug dependence, their words not mine, and where any of the substances controlled under the Misuse of Drugs Act are involved. No prizes for guessing what significant factor is missed out of that kind of list of drugs is alcohol, which of course isn't controlled under the Misuse of Drugs Act. For the purposes of our monitoring, we wanted to consider all deaths in treatment and look at whether or not that there was a link between drug and alcohol use and death, and we also, of course, wanted to include alcohol. So just in terms of what informs the process, I'll just get these up. So in terms of the online drug-related death reporting system, we take information in from the coroner, from the treatment provider, and that informs this online record. At the same time, there is an alert that goes off to people like myself, so local authority commissioners of alcohol and drug treatment services, to notify us that there has been a death in the area. This is just a kind of a screenshot of that online record that's been developed. And you can see across the tabs across the top there gives us a number of areas where information is taken. So we have information on education and housing status, details of the death, a medical history, substance use, treatment history, coroner information, and so on. Just in terms of the substance use treatment information, and there's a couple of items highlighted there, I think it's of particular interest, and Mark will expand on this, of particular interest that we look at the dose levels for people who are on opiate replacement treatment, and also injecting status. I know Mark will go into more detail, but I think it's particularly interesting that what we've seen as a result of this kind of flies in the face of what we're told through national policy, that there's a decline in injecting drug use, and I think that's always necessarily the case. I think what's more likely to be the case is people who do continue to inject drugs just don't report that to the treatment services. We also take in data from other sources, as I say, particularly from needle and syringe programs, from brief intervention providers, from the criminal justice element of the treatment system, and from our colleagues in social care. And that will then go into, all goes into a report which we consider for every single death in treatment as a way of actually feeding some of the elements that we learn from that process back into the system, and hopefully to improve practice. Okay, I'm going to hand over to Mark now to sort of show us what we learned from that, what we find out, and what the benefits of that process will be. Hopefully I haven't used it all the time.
Just the net button.
Okay,
That one there.
thanks.
Okay, so as Alan said, the information that gets collected through this process goes into an individual case level report for each person. That gets then considered at a quarterly panel which meets, and we have representation on the panel from the treatment provider. We normally have the consultant prescriber from the treatment service, a public health commissioner from the local authority, and it's the local authority that fund this work, somebody from social services, and any other relevant services to the cases that we're considering. We invited a number of relevant specialist guests along to the panels, areas like COPD and the hostel section. I'll talk a little bit more about that in a second. And then also a chairperson, which is normally myself. So The system, it began, as Alan said, in Sefton back in 2015. We've rolled it out now to 6 other local authority areas within Cheshire and Merseyside. So we have 9 in total, and 7 of the 9 operate the system. 542 deaths were reported to the system up until the end of last year. We've had 37 panels take place. The panels work differently for different areas. So some areas like Liverpool have more than one treatment provider, and so they will both attend the same panel, obviously. Other areas have the same treatment provider in different local authorities, and they sometimes have a joint panel, so they work differently. Again, we've had various specialists who have attended those panels. So what has the data told us so far? Most areas so far we've had more deaths reported by the treatment provider than the coroner, and the only exception to that really is Liverpool, kind of a bigger metropolitan area. It does kind of go against a little bit of the national picture with this, where there's more deaths being reported by the coroner, so that's people that are out of treatment. The average age of death locally is between 48 and 52, which is higher than other comparable areas. So we've worked with other areas such as Birmingham, which is another city that has a real issue with drug-related deaths, and their average age of drug-related deaths is more like 40. So people are dying at an older age locally. However, some areas have got much lower ages for the coroner deaths. So for people that are out of treatment, we're seeing them dying in their late 30s compared to being in treatment, which seems to be about a decade later. Drug toxicity is still the main cause of death identified, so this is primarily opiates, but we are seeing increasing numbers of cases of alcohol toxicity, so essentially an overdose of alcohol, which when we started doing this even three or 4 years ago, we weren't seeing to the same extent. There's also, in the last year, particularly a high proportion of prescribed medications, so SSRIs and other similar medications that are appearing in the figures as a cause of death. And also we're seeing rising numbers of cocaine deaths, and that's something that reflects the kind of national picture as well. Some of the key recurring themes then across all areas. A higher proportion of female deaths compared to numbers in treatment are using NSP services, so there are more males than females dying, but relative to numbers in treatment or numbers used in syringe exchange, we're seeing disproportionate numbers of females coming through these figures. A significant number of people living alone, and this has been a real thing that we've noticed over the last 18 months in particular, which kind of makes us consider all types of things in terms of naloxone, for instance, which it would be useless in a setting where somebody's living alone, and kind of considering what impact this has on messaging that we're giving out. High number of prescribed medications from GPs, so this has been something that's almost since when we started. I took a screenshot from one of the most recent drug-related death cases, and you can see this is just an example of the types of medications that people are being prescribed. And I suppose one worrying element of it is that some of those would contraindicate with being prescribed an opiate. High number of individuals with COPD respiratory problems, so certainly in terms of the ageing cohort, which there's been a lot of discussion around in recent months, this is a real issue. Deaths occurring in hostels, or where individual has recently been a hostel resident, and this is something in the last year in particular we've had across different local authorities, deaths that have taken place in the hostel sector. End of life care again for the Asian cohort is a real issue. We've had lots of contact with palliative care services around how you meet the needs of this client group. There's situations, for instance, of individuals in their 40s or early 50s going into nursing homes, and the difficulties that causes them and also the residents of nursing homes, and kind of the inappropriateness of the setting really, and it's one of those things that we need to think about more. As Alan mentioned, substantial numbers are injecting, so we'll often have a case where their drug treatment record will say never injected, and then we look at the syringe exchange data that we match as part of this system, and actually there's been a number of transactions, sometimes hundreds and sometimes very recent. So it's telling us a very different picture from the information we're getting from the national treatment system. And also depression and anxiety being the most commonly identified condition. This comes through drug treatment reporting, and it's self-diagnosis, so you have to be a little bit cautious in terms of the numbers around this, but certainly in terms of people self-identifying a condition, this is the main one that we're seeing recurring. In terms of some of the benefits in the future then of the system, I think people have fed back to us that they do think it's a useful opportunity to discuss practice in a non-blame environment, and particularly where more than one area is involved. So again, within Liverpool, there's services, different treatment services that contribute to the same panel, and they've said that they actually find it a good space to be able to talk about things that have gone well, things that haven't gone as well, and learn from the other service. Specialists attending the panels have assisted in the establishment of improved pathways. So again, palliative care is a good example where in several of our areas now there are conversations happening with Marie Curie, end of life, Macmillan type services, and just beginning to establish and put into place some pathways and relationships between themselves and drug services. Having the same system pan-area does allow for that sharing of local experience and themes, and it was one of the recommendations from Public Health England that areas don't do this in isolation, they do it in conjunction with other surrounding local authorities, and we've certainly found that's been useful here, particularly for some of the smaller local authorities where some of these themes might be difficult to pick up from their small numbers. We're looking at receiving civil registration mortality file data this year to add into the system. A number of years ago we had this before the Health and Social Care Act stopped everybody sharing data, and that's useful because apart from anything else they will give you underlying and secondary cause of death, which makes the analysis much easier to do, and again allows us to pick up themes perhaps quicker than we would do using free text. And then finally we had our first cross-area learning event which took place in October last year. Here's a photograph of it. And it was a really good opportunity to kind of share experiences across all the areas. We had representation from elsewhere in the country, and commissioners from most of the areas attended too, and I think it was a really useful event. And we'll be pulling together an event over this coming summer with Public Health England, so we can start looking at some tangible outcomes from the changes that have been made as a result of areas implementing this process. Thank you.
Thank you. Let me first introduce Mark, and then we have some room for questions.
Yeah, well, just a quick introduction. So he is the Intelligence and Surveillance Manager at the Public Health Institute. And Mark, you have a background in the field of drugs and alcohol, having worked for 12 years originally within the scope of addiction services in the area of mental health and NHS Trust. Okay, any questions for Mark?
Or Al.
True. Yeah.
I have a question.
Sure.
Do you have a drug monitoring system in Great Britain? In the UK? Drug monitoring?
Yeah, so we have something called the National Treatment Monitoring System, which is for individuals in treatment. What we don't have is any national system for those low threshold services, so syringe exchange tends to be just monitored locally.
Do you see any trends from the US now coming to the UK? With fentanyl use and overdose death?
A little bit, although it's very, we haven't really had it around Cheshire Merseyside. It seems to be quite localised. There's some peculiar patches of the country that have had fentanyl deaths. Also with which we haven't really mentioned today because it's not been an issue locally, but the novel psychoactive substances. In Birmingham, for instance, they've had 20 deaths over the last 18 months from spice, or whatever you want to call it, which we've not seen locally at all, although I know that Manchester's had issues. So you tend to find quite localised issues with particular substances. I think the parallels with the US are just that we've seen that same steep trajectory, and I know that they've had it worse over there because of the issues with historic opiate prescribing, which we've probably not had to the same extent here, but still we're seeing that same direction of travel, sadly.
Yeah. Yes, Dave.
Have you had any resistance from any of your partners? I'm just thinking, you know, the various multi-agency things you look at, domestic abuse, etc. Putting a new one in there, I just wonder whether anyone's going, well, do we have to do this? Does everyone play nicely?
I mean, it's because this is taking place against, as Alan said, a context of really significant cuts that we've endured here over the last few years. Services are under immense pressure. So it's fair to say that when you suddenly say to key workers that there's a new bit of work for you, they're not delighted about it. But actually, I think since the panels have started to take place and bedded in, people have started to see the value of it. I don't think people are enthusiastic, but they're not kind of resistant anymore, if you like.
Good. And you can still, I mean, we would struggle, I think, in some London boroughs to identify someone who saw it as their job to hold the ring, really. Because, you know, we've kind of contracted out everything. I mean, there's still drug services in every borough, but someone's trying to find who identifies being responsible within a local authority. Not always easy enough.
No, and I think maybe because we've had a historic relationship with the local authorities, because we've provided syringe exchange monitoring for getting on for 25 years now to some of them, and we worked together for a number of years, that almost some of those relationships were already there.
Yeah, and I think that's probably an important point to make, that, you know, in spite of the fact that we have experienced such savage cuts in our drug and alcohol budgets within local authorities, we've been very fortunate to be able to retain the services of the Public Health Institute at Liverpool John Moores. As Mark says, we've commissioned monitoring services for non-structured treatment for quite some time. And so this was very much a response to the kind of increasing visibility locally around the drug-related deaths. So I think you're right, it's difficult often to get partners on board, but when you sell that as being part of the solution, because, you know, there's not very many of the partners within the treatment system that don't want to do something about the numbers of drug-related deaths. So that's the way that we kind of encourage people to come with us on that.
Thank you.
Thanks so much, Mark and Helen. Thank you. We go to the next speaker. Yes.